I just muted everyone. But you all have the ability to unmute yourselves. Mm.
Okay, Marie, if you want to start going through a roll call for REMAC.
Okay. I just want to ask a question first. I have some people who are not members who want to come into this meeting.
This meeting is an open meeting, and they have to be allowed to come in.
Okay, give me a second.
In which case, that meets our open meeting rules. You're muted if you're speaking.
I'm now speaking again. If you've got two problems. If you let everyone in, that's fine, but you may be Zoom bombed. You are allowed to meet the open meeting law by also streaming this on YouTube or whatever. And when we do let someone into this meeting, which is fine, Marie's gonna now have to do a complete roll call vote for every single vote, because you will not know who's allowed to vote and who's not.
Correct.
Yeah.
So
it's your choice. I mean, the reason why you generally don't let people in is because you don't want to be Zoom bombed.
Well, yeah, I know the person is just it's not a member, and
the pros and cons.
Okay, just give me a second and let me let this person. Dr. Schenk, if you let me just send this invite out so that we don't get in trouble for nonsense.
Okay. That's good.
Oh, come on. Okay, save it. Just save everything. Stupid thing.
You can set up Zoom meetings to allow you to stream them online. So people
Yeah,
can
no,
watch
I've done that before. It's just for some reason, it's not letting me stream tonight. I've done it before on Facebook and on YouTube, and I don't get it. I don't know why it's not letting me do it. But it is what it is. I have to figure out later why it's not working tonight. I really don't understand it.
Want to just record it to the cloud, Marie?
Well, yeah, it is recording. Well, it was recording. It's recording right now. And then we'll post it. But I like to do it live so that people can watch while we're actually meeting.
You actually have to do it live to comply with the governor's order.
Yeah. Yeah.
Or you have to let everybody into your meeting, anybody, including those people who are going to want to Zoom bomb you. So you have two choices. You let everybody in, the whole world, and then you can get Zoom bombed, as has happened.
Yeah.
You only let in the members, and you record, and you stream live. Those are the legal choices. Otherwise, any decision you make can be challenged in court.
Okay, so this meeting is open. We are letting anybody in as long as they're registered, but they are allowed to come into the meeting.
Yep.
We are recording it. We are not live streaming it because of technical glitches, but we are following the open meeting law as we have to. So
yes.
You could go through a
roll call vote. I mean, a roll call attendance. Okay, we're just going to do that really quick. Of course, that was the one thing I closed, right? Okay. Give me 1 second to open up my attendance. Sorry, just give me 1 minute while I get this attendance up and running. Here it is. I'm just letting in the last 5 people in. Okay. Okay, we're going to go through the attendance one more time, and then I'm going to turn this over to Dr. Schenker. Please answer when your name is called. Robert Winchell. Joseph Schenker.
Here.
Robert Ackerman.
Here.
Nick Alexandru.
I'm here.
Okay. Eric Cohen. I saw Eric.
I'm here. I'm here.
Okay. Mimi Langsam.
Here.
Mimi Langsam.
Oh, Mimi's not been a member.
I know, but I can't take her off the list until we finish the bylaws. So I'm calling her name. Kevin Munjal. Do we lose
I'm here.
Kevin? Okay,
No, I'm
great.
here.
Cindy Basilios.
Here.
Great. Grace Cacciola.
Here.
Okay, Dario is deployed. Glenna Seda.
Here.
Bradley Kaufman.
Here.
Doug Isaacs.
Here.
Nathan Reisman.
Reisman.
Here.
Reisman, sorry. I'll never get it right, you know that. Kevin Ward.
Here.
Thanks, Kevin. Anne Marie DeGenti.
Here.
Samia McKeachin.
Here.
Allison Burke. Jeffrey Rabrich.
Here.
Reed Caldwell. Jonathan Berkowitz. I know I saw Dr. Berkowitz. Lewis Marshall.
Here.
Michael Redlener.
I'm here.
Hello. Laura Ivacoli.
Here.
Great. Stuart Kessler.
I'm here.
Thank you. Matthew Fink. Wallace Carter. Dominic Battinelli. Efren Rendon. Peter Wyer.
Here.
Paul Barbara.
Present.
Okay. David Benelli.
When your name is called.
Pain. Celia Quinn.
Here.
Hi, Celia. Timothy Stiles. Mark Cantor.
Here.
Joseph Bove. Sean Graves. William Fisher. Robert Krupe. Jessica Van Voorhees. Art Cooper. Dr. Cooper, you still here? You did your Langsam?
Present.
Yes, I'm still here.
Okay, great. And Dr. Shalish? Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 14. We have a quorum. Thank you very much, ladies and gentlemen. And there's Dr. Berkowitz. I just let him in again. Okay. Okay. Shoot. I'm going to make you the host, Dr. Schenker.
Sure.
Okay. If you need me to post anything, I'll just take host back.
Okay, great. Okay, thanks everybody for joining us, and welcome to the new season of our REMAC meetings. We will follow the standard agenda and go through things one at a time. If anybody has any questions at any time, if you can use the raise hand function on Zoom, that would make things a lot easier. If you're not on a computer and you're on a phone, you can unmute yourself. I ask that you unmute yourself and just let us know if you need anything. Okay, so approval of the minutes of the June 23rd meeting. This was sent out via email. Does anybody have any questions about that joint REMAC medical standards meeting minutes? Seeing none, I'll entertain a motion to approve those minutes. All right, I got a hand from David.
Motion approved.
Excellent, and a hand from Paul. Thank you guys very much. Okay, correspondence report. Marie, if you have any correspondence, please.
It was that very short report that I gave before, and it's just,
You have to give it again. So this meeting
Okay.
is separate from the previous one, unfortunately.
Matthew Harris, again, put in his interest in taking the pediatric seat on REMAC. Lincoln Hospital is now thrombectomy capable, actually since July. We have 2 enforcement actions from the Department of Health. Thomas Dean, who's actually in Saratoga, was revoked as of July 6th. Latasha Wright, she's a Staten Islander, and her certification was revoked as of July 13th. I have spoken to fire department with regards to that enforcement. And that's all we have for right now.
Thank you. Okay, so for those of you who don't know Matt Harris, he was a member of this committee prior to moving to Denver. He is back. He is board certified in pediatric emergency medicine, and EMS medicine. He was previously a member of this committee, and I think that him joining this committee as a member would be very beneficial. And I'd like to move that we accept him. Do we have to do a roll call vote to accept him, or can we not?
No, you have to do now roll call vote on anything because you're not guaranteed that everyone here is a voting member.
I see. Okay. In that case, I would like to move that we vote Matt Harris into the position of pediatric emergency physician. Is there a second?
I'll second Redlener.
Great. Does anybody have any questions or comments or concerns about Matt Harris as our pediatric emergency medicine physician? Okay, hearing none, Marie, if we could go through just the physicians, a roll call vote to accept Matt Harris as our pediatric emergency physician.
Okay, let me just set this up. Today is, okay, so your choices are in favor, opposed, or abstain. Dr. Winchell is not here. Dr. Schenker, I'll leave you for last. Nick Alexandru.
In favor.
Okay. Kevin Munjal,
In favor.
Cindy Basilios.
In favor.
Thank you. Okay. Yeah. Glenn Seda.
In favor.
Thank you. Bradley Kaufman.
In favor.
Doug Isaacs.
In favor.
Nathan Reisman.
Yes, in favor.
Jeff Rabrich.
In favor.
Jonathan Berkowitz.
In favor.
Okay. Lewis Marshall.
In favor.
Michael Redlener.
In favor.
Matthew Fink or Wallace Carter. Okay. Laura Ivacoli.
In favor.
Peter Wyer.
In favor.
Paul Barbara.
In favor.
Great. David Benelli.
Affirmative.
Affirmative. Celia Quinn.
In favor.
Mark Cantor.
In favor.
Joseph Bove is not here. William Fisher. Robert Krupe. Jessica Van Voorhees. Arthur Cooper.
Yes.
I thought Dr. Fisher was here. Did I leave anybody off that's a voting member? Okay. 1, 2, 3, 6, 7, 10, 11, 12. Okay, we have 18 votes in the affirmative, so the motion passes.
Great. I will bring that forward to REMSCO for their notification next week, I believe. Okay, thank you very much for the correspondence. Subcommittee reports. Executive committee met briefly to discuss the tone and the what we're going to be doing going forward. A lot of it you heard during the medical standards meeting, and you'll hear during the medical standards report. And we'll talk a little bit more about other things a little bit later in this meeting. Medical Standards Committee, Dr. Benelli.
Yeah, so Medical Standards Committee met right before this meeting. There are no action items to be brought forward to REMAC. We discussed the format of holding such meetings in the era of Zoom meetings and not in-person meetings. There were two suggestions that were brought forward. The first one was to make two separate meetings on two separate days, which some people opposed due to schedule constraints. So people are more in favor of holding one joint combined meeting, and we have to, I think, figure out the mechanics of this, the details of how we would do that. Then there was another suggestion to maybe change the hours of the meeting, since we're not meeting in person and there's no parking issues anymore at the REMSCO building. Perhaps to make it earlier, and we agreed that Marie would send out a survey monkey for, I guess, 3, 4, and 5 to see what people are in favor. CNC committee reported that they're looking to field suggestions as to what targets they would look to achieve this year. In addition, there is a need to continue looking into physician certification, OLMC physician certifications, and into creating more a more robust test exam. I believe that I have not left anything out, and that would be the end of the medical standards report.
So David, there was also a discussion about adding a new standing committee to the medical standards.
Oh, that's right. That's right. Go ahead.
Committee, an interfacility transport committee to discuss both the legalities in terms of Article 30, Article 28, as well as guidelines, and Dr. Berkowitz so selflessly has agreed to chair that committee. So thank you very much, Dr. Berkowitz. We appreciate it, and we look forward. Anybody who's interested in participating, please email Marie or myself, and we will forward it to the right people. Anything to add, John?
Nope, I'm just looking forward to having this be a vibrant committee.
Thank you. Okay, anything else, David?
Nope, I think that's it.
Any
We'll
questions,
look forward to it.
Ellie, about the medical standards report? I'm looking for hands up, so if I don't see any, I will move forward. Good. Okay, next is the Quality Assurance Committee report. Dr. Redlener.
Hi, Joe. Thanks. So I'm going to just talk about 3 quick items. We haven't met since June, but the 3 items that we are working on, the first 2 I'll talk about, and then I will turn it over to David to talk about David Benelli to talk about the stroke systems of care update. As everybody knows, the First Watch program has been adopted by our region as a way to put together regional data on STEMI and stroke. We're very close to having a regional dashboard with looking at key indicators around both stroke and STEMI. It's really the first time that we'll be able to look at a live dashboard around some of these measures and metrics. There are some kinks that we're working out. We've been meeting with the AHA group and the quality team and the folks who've been working on this project, the executive committee, and we hope to have that to present at the next REMAC meeting. That will enable us to start the process of really talking about how we do data-driven quality improvement. And the second thing that I'd just like to mention that we've been working on, and Joe Ranieri has been doing a lot of work related to this, but thinking about a REMAC kind of after action report related to the pandemic. And again, it is in the beginning stages. It's going to be going to various the executive committee and other folks to review, but we hope to have some information. If there's anything that you'd like to contribute or make sure that is included, I would definitely like that feedback. So those are the 2 major items of business that we'll be discussing moving forward, and I will update you at the next meeting.
Great. Thank you very much, Mike. And just before listen, if you keep making right turns, you're going to be in the same place, just so you know. But David, if you want to present the stroke data, that would be great.
Absolutely. I'm going to try to share my screen. No, you have to allow me to share the screen.
I will allow it. Hold on. All right. Can you do it now?
Let me see. Yep, I'm going to share. Let me see. What am I going to share? I'm going to share a screen. Okay, and I'm going to start the broadcast.
You keep making right turns. Does that mean that you're like in danger of having a stroke?
Well, what I'm going to do is so it's been a while since we reported back to this committee regarding the New York City stroke system of care and the implementation and the data. It's been actually 10 months since that happened. Can everyone see my screen, by the way?
Yes.
Perfect. So after a long COVID pandemic hiatus, we did get back to looking at the data, and that's what we want to share here today. It's 16 months of data from the beginning of April 2019 until the end of July 2020. In total, we had almost, so when we look at the all online medical control call volume with LVO related New York City SLAMs calls of 4 and greater. So there were a total of almost 2,000 calls since the beginning of this project. Out of those almost 2,000, about 1,300 were transported to, approved to transport to a thrombectomy stroke center, i.e. a place where they can do a clot retrieval. The rest were transported to primary stroke centers. The main reason for transport to a primary stroke center were obviously New York City SLAMs of less than 4, so 3 and below, or a last known well of 5 hours or greater. And this is kind of a pie chart that depicts that the same thing, that really the majority are, because the SLAMs, the New York City SLAM score is less than 3 or less. So that's almost 40%. Another 25% are those that had a window greater than 5 hours since the onset of symptoms. So with regard to the outcomes, so of the almost 1,300 patients that were transported to thrombectomy stroke centers, so a large majority of them, 1,038 patients were actually diagnosed in the hospital with having a stroke. And by the way, when I was updating these numbers and I was I was comparing this to the 6 months numbers, that was the last time we reported, the percentages remain remarkably the same, which is outstanding. So out of the 1,300, about a little bit over 1,000 had a stroke diagnosis. Of those, 209, that's 16%, had hemorrhagic strokes. TIAs were 42 patients, that's 3.3%. Those that didn't have really a diagnosis were 9, which is a little less than 1%. The rest had ischemic strokes, that's 778, so 60% out of those that were transferred to thrombectomy centers, and out of those, 32%, or about half of all ischemic strokes were diagnosed with a large vessel occlusion, so 412 patients. Main alternative diagnoses remain also unchanged. So seizure, syncope, weakness, dizziness, conversion disorder, altered mental status, cancer, encephalopathy, so other reasons that might mimic stroke. But the majority really are seizure and syncope with conversion disorder right below it. So of those 412 LVO ischemic stroke patients, about 65%, 268 patients had a thrombectomy performed. The majority of them had findings in the middle cerebral artery, 75% of those, which is not surprising. A clot was successfully removed in the majority of these patients, 92% of those patients. Main reasons for not performing thrombectomy remain unchanged from, again, from the data we presented at 6 months. So unfavorable brain imaging, aspects scores of less than 6. When the risks are outweigh the benefits, or there's too large of an occlusion. When there was actually improvement, when TPA did actually work, and there was an improvement, or when the interventionists could not identify a proximal occlusion, or there was significant pre-stroke disability that would preclude showing benefit after the procedure. The rest were symptoms that resolved or were resolving even without TPA, so kind of a TIA presentation. And then, of course, there's patients or families that refused. With regard to the median times, on-scene time to hospital arrival, the median time is 36.3. En route to the hospital, the median time is 7.8. And that, again, these numbers are not significantly changed from the 6 months. On-scene time to first pass, also not that much change, 177.5 compared to 182 at 6 months. From hospital arrival to first pass, So this has improved, which is expected. There's a learning curve for the thrombectomy centers. It's still a little high. We want to see this number lower. And that's, again, something that our hospital partners need to keep in mind and focus on lowering this number. When we look, this is a map of New York City where we looked at the average travel time from scene to hospital in minutes by zip code. So really the majority of New York City is below 20 minutes. And there's there are very little places in New York City, not surprisingly in the Far Rockaways, where the transport time is a little over 20 minutes. And it's namely because, you know, St. John's Hospital, the only hospital at Far Rockaways, is a primary stroke center and not a comprehensive stroke center. So that's kind of expected. That is more or less the data, the 16 months data. There's a second part of this presentation which I want to discuss in a moment, but if there are any questions about this data, I'm happy to entertain them before we proceed.
Dr. Winelli, it's Morty. I just have a quick question on the
Sure.
scene time to hospital time. Is there a comparison by any chance to those same times prior to the new protocol?
Good question. That is something that we can retrieve. We do not have that here to present. That's something that we can definitely look at. I would like to believe that you know, that the scene time has improved because of the heightened awareness. Michael, you wanted to say something?
It's Ben Zabar. I just want to point
Ben.
out that in the old protocol, they were not calling medical control. They were just transporting. So because generally they're calling telemetry before they transport. So even if they're hurrying to get off scene, the telemetry consult is going to increase the scene time a little bit. So it's not exactly apples to apples if you compare it to before the protocol, but it might be worth looking at anyway.
Absolutely, and that's a good point. Even though the telemetry contact is we attempt always to keep that to a minimum. Any other questions?
David? Okay. Yeah, hey,
Yes.
it's John. A couple quick questions. It's a great presentation. Thanks for the data. Have you done an analysis to look at the individual elements of the SLAM score to see if any of them are more have a higher predictive value, either for a presence of LVO or no presence of LVO? That's question one. And question two is, have you done any analysis of the variation between hospitals in terms of their arrival to the first pass times?
Two questions. It's two good questions. I'll answer the second question first. We do know the data at a hospital level. We clearly would not share that with anyone other than the hospital itself, and we are looking into how we're gonna share that. You know, it would probably be it would probably be a range, and it would probably be similar to the way we share data on with regard to STEMI. It would probably be in the same format. Okay. So that's something that we're looking into. With regard to your first question, we are looking. We are in the midst of a research initiative to look at to validate the SLAMs, the New York City SLAMs scale, and we will be looking at those elements. So that's something that's in the works.
Great, thanks.
Dave, is that travel time for these stroke calls, or is that any call?
I'm not sure I understand the question.
The map you have up with the various zip codes, is that the call types we're talking about here? Is this the stroke call types, or is this all call types? Okay. No. Just want to clarify. Okay.
Yeah,
Isn't it just the the LVO calls specifically?
That's correct. Specifically the LVO calls.
No, go ahead, Michael. I'm sorry.
No, I believe that it's David, you can correct me if I'm wrong, but it's the cases that were transported to a thrombectomy stroke center.
That is correct, because that's what we wanted to make sure that we're not, getting excessively long transport times. Okay, if there are no further questions, I want to move to the second part of this presentation, which we probably should discuss at REMAC and decide how to proceed. And that's this is the following graph. what we've been noticing, so this is a graph that depicts the total number of online medical control contacts for LVO from April 1st, 2019. So from the beginning of the project until August 31st. So this is a little more frequent data because it's until the end of August. And what we have been seeing is a steady, a steady drop in the number of contacts to OLMC for large vessel occlusion calls. And that drop has been there even before COVID. The big era of COVID in New York City is kind of marked between these two vertical red lines. And clearly during the COVID period in New York City, we've seen a significant drop, in all calls. We all know that. But we've seen a drop that has been steadily declining over time, even before COVID, and is not recovering even after COVID. There's a little bit of uptake in the past month, but we're still not reaching the numbers that we were, where we were even before COVID, way before COVID. And that was something that was very concerning for us. And just to make sure that we're not, that those numbers are real. So this is only FDNY data because what we did was we took all the EPCR data, and we have only EPCR data for FDNY units that's readily available. And we checked all the EPCRs with a New York City SLAM score of 4 or greater that resulted in online medical control contacts also over the same period. And we've seen a similar drop. So we're assuming that this is a real drop in the crews that encounter patients that potentially have a New York City SLAM score of 4 or greater in contacting online medical control. So this was, for us, alarming enough to decide that we need to do some sort of intervention to make sure that our providers are refreshed and reminded about the importance of identifying strokes that are potentially devastating, like large vessel occlusion strokes, and contacting online medical control and getting transferred to thrombectomy stroke centers. And what we're doing now in the New York City Fire Department at the Bureau of Training, we actually incorporated a small portion, a number of slides with a number of cases to refresh our providers' memory with the New York City SLAM score and the importance of contacting telemetry. And it's easy for us to do because we are now in the midst of a mandatory unified protocol training for all our providers. So we incorporated into that, purposely into that training, a small portion that talks about New York City SLAMs. Because—
Quick question.
Yes.
Do you know how many patients have an SLAM score of that meets LVO criteria but did not get a telemetry contact?
That is something that I don't have readily available here. That is something that is data that we do have.
But the question is this a drop in the volume, or is this people afraid to call EMS because it's post-COVID and it's still in that?
Well,
year?
I would say that would be true if it would not be there even before COVID. And when we did look, I did look yesterday. Well, with Michael, we were looking at, we compared the 6-month, proportion of LVO patients out of the total call volume, and the percentages remain the same. So this is probably real.
And to what Shanker's asking, I think the answer is on the screen, because you're asking what percentage of people with a score that should have gone a call that didn't. It's just, the 100% minus whatever's on the left. So like in, May, it looks like, 35% that met the criteria called. So that means 70% met the criteria and didn't call, right, Dave? I think if I'm reading this graph correctly.
Yes, it's in percentages. That's correct. Well, it was never 100%, right? But
right. But so, it's just so Shanker, it's just the whatever percentage is, the opposite is what you're.
So this is okay. So you're saying that these are okay. I hear you. I'm sorry. My bad.
Okay,
No,
so
I think the first graph he did was the total number, and then this is just the percentage. He ran it just for FDNY.
that's just the percentages for FDNY where we had EPCR data. That is correct. So the bottom line is since the New York City SLAM's Large Breast and Occlusion Thrombectomy Center initiative is a regional initiative, we have provided REMAC with the training material that we're using on our providers now during these mandatory protocol, unified protocol update. And we really believe that there should be regional training as well to refresh our providers. So this is what we have to present today, and I think we should probably open this up for discussion.
Dr. Manelli, it's Morty. So since you sent the email in the summer, TrainingNet has been working on a recording that will hopefully be done in the next 2 weeks that will provide the regional training. We put a big emphasis on this as a result. There's going to be also, we're utilizing those same slides for the material that was provided. We're also going to run a scenario and drill a point home specifically on this one piece. This is actually one of the few protocols we have left to record at this point.
Excellent, fantastic.
But it is built in.
Excellent.
Perfect.
And it will be tested on as well.
Any other questions for Dr. Benelli? All right.
Hey Dave, this is Kevin. This is Kevin. Can you hear me okay?
Perfect.
Yes.
The reason that we are calling telemetry, I believe, if I recall correctly, and I may not, was because we needed to get around the fact that the state did not have sort of designations that we could utilize in order to make this sort of a EMS-driven kind of protocolized destination decision. Is there any update on sort of progress at the state level in terms of identifying thrombectomy capable centers such that we could consider in New York City whether or not the OLMC contact is still necessary for a patient level decision?
David, can I answer that?
Yes, please.
So, Kevin, there's a 3-year transition period in which centers that have gotten their primary stroke center designation have the opportunity to submit to the thrombectomy stroke center, and during that time will probably be wise to stick to the online medical control. So it's at the 3-year point from when the regulation went out, which was right around the same time that we went live with our system. So I would say we can consider it, but I would consider it probably a little bit further in the future.
Yes, I agree. I mean, it's really important for us, especially these still early phases, to have very close monitoring and quality assurance on this initiative.
And the other question is when they don't call med control, do we know where they're ending up? Are they ending up at the correct destination, but not authorized, or are they ending up at the wrong destination?
That is something we have to further look into. I don't have that data readily available over here.
And Kevin, that part of the analysis is, we're looking at doing a before and after kind of assessment, in conjunction with the AHA and get with guidelines. But again, that's a little more of a deeper dive, but definitely in the works.
Sounds good, thank you.
Okay,
I have a question.
Sure.
First of all, David, Michael, and the people that worked on this, this is incredible data, and I really want to give you a little bit of applause here. I mean, 80% predictive value is incredible for something as vague as this, especially to find the procedural candidates at such high alacrity. Question I had is basically, does the predictive value of the test change with time? As you roll out a new treatment algorithm, was it being applied to true negatives who would have changed the true number of stroke patients in the region? And now that the training and people more familiar with it, we're seeing maybe a leveling off to what the true number of people with disease in the population are, and the test is being applied appropriately. So I hope I'm explaining myself well, but it's reasonable that the test was being applied inaccurately on the launch, and now a year in is being applied to the correct population.
Michael, do you want to answer? Do you want me to answer?
You know, Paul, I don't think we saw much of a difference in, you know, the first 6 months versus the 16 months in terms of, yeah, you know, but again, I think that, you know, we don't have the complete picture because we don't know who we're missing in this. Like if somebody doesn't call or get a, you know, we just don't have all of the data to make, you know, to present that. But, you know, but I don't think that the percentage of, you know, the calls going through to a thrombectomy center has changed much.
I would add to that, you know, this would be part of the data information that we're looking as part of this research initiative to initiate the New York City SLAMS data. There's always, as Michael said, you know, there's always an issue in finding the denominator of everyone. And that's something that we're working on as well. In addition to everything else, in addition to what you're saying, Paul, you know, that people might be better at administering the test. You also have the confounding factor of COVID that kind of falls into the data and messes things up. So, you know, this is still work in progress.
Hey, David?
Yes.
Yeah, I just put an article in the chat. Obviously, it's a pretty small sample size article, but they basically it was an article looking at retention of stroke-related education in paramedics, and it showed really a 3-month intervention window for their education curricula. So I think that definitely with what you're planning on doing is probably what's needed.
Excellent. Are there any further questions? So one last point before I turn this back to Joe. We really need to thank our FDNY epidemiologist, Dr. Liz Lancet, who has been working diligently together with one of our paramedics, Vince Carano, on patiently collecting all the data and all the contacts with the individual hospitals and entering this data into a large database that we have right now. And it's really their hard and strong work and Liz's deep understanding of the epidemiology that is helping us present this data here today. So thank you very much to both.
Great, thank you very much.
Okay, I'm going to stop sharing the screen. Just 1 minute. Okay, you should have it. Thank you.
David, I appreciate that. Okay, next on the agenda is training and education. Mr. Lax, if you could give us an update.
Sure. Hi, everybody. So as mentioned earlier, training and ed has been working. We've met quite a few times, almost reminiscent of the protocol meetings last summer, to record a interactive training using the materials from the fire department. We're going more or less in order, in the same order as the training materials that the fire department provided. Stroke happens to be at the very end, which is why that's still one of the last few remaining. It has turned out to be that doing this via Zoom, the recording is a little more challenging than expected, which is why it's taking a little longer than we thought. I actually had a target date of being done by September 1st, which is not. It's looking more like we'll be able to have it up and running closer to October 1st, which will give us the last quarter of the year to get the training done regionally. Once it's done, the goal is to get it up on the state's Vital Signs Academy, which is seems to be a better platform to run this type of training. And the Department of Health has been using it pretty successfully throughout the summer, running classes and CMEs. And that's the goal. So there'll be a couple of interactives. There are a couple of scenarios that are discussed and talked through and simulated, at least on a screen. And with quizzes in between modules, and then an exam at the end that will provide a certificate.
Great. Any questions, Mr. Lax? I see David.
No, I just wanted to add something. Another thank you to the stroke information is, of course, to Pam, who is our medical director for QA/QI, who has also put in a lot of effort and a lot of thought into this. And of course, to Michael. Thank you. Sorry about that.
If there's a, Dr. Manelli, the next week or two, if any more information happens to pop up or any answers to any of the questions that were brought up, please let me know. If we can build that into the training, we certainly will.
Great. Anything else, Morty?
That's it.
Any questions for Morty? Okay. Is there anybody from RTAC on the call? All right. Seeing none. Regional Council, you did, Joe?
I don't have a report, Marie.
Okay. I think they're meeting next week.
Right.
Yeah, I sent the report actually to Dr. Krupe.
Sorry, Bob, are you here?
He's not here, so give me a second. I'll pull it up.
Okay, so while we're waiting for that, Lou, if you want to go over the CMAC update.
Yeah, hi, how are you, everyone? Yeah, CMAC met recently. The protocols that New York City sent up went through, and that's really all I remember. There was some discussion about
excuse me, Dr. Schenker, I did send you the report for CMAC.
I wasn't there. That's why I asked Lou.
Okay.
I have the report. I mean, I will let you know that there is a motion to approve terbutaline IM for bronchospasm in ages 12 and above, and at a different dose for ages 6 to 12. There's also a motion to affirm that EMS providers can administer vaccinations if trained. It does clarify scope of practice. There's also a motion that that EMS providers, when trained and equipped, can conduct oral and nasopharyngeal swabbing for testing. And then our New York City protocols were approved.
Joe, you described those as motions. Could you just clarify, are those still pending or are those approved? Or
These were affirmations. They were not voted on, meaning they were not. These were affirmed by CMAC. That's how it came down. But they were not, and these were approved. They're just not anything changed from there.
So Joe, it's Doug. In regards to the vaccinations, so since that is, if they're trained, is that something as a region, we can put together some materials and maybe bring forth the protocol?
I think that's a great thing to discuss at protocol. Before we get into protocol, how do people on this call feel about vaccinations and using our providers to provide vaccinations if necessary? I think that's something we should discuss prior to sending it to protocol.
Yeah, this is Lou, just a comment on that. So right now, pre-hospital providers can administer vaccines under an order from the commissioner. So this was not like a blanket approval, although we're trying to move to that point so that regions can determine on their own or can activate it on their own for pre-hospital providers who are trained, can administer vaccines and can do nasopharyngeal and oral swabbing for testing.
So, hey, Lou, it's Doug.
Yeah.
I mean, if the motion that you had at CMAC, it's within the scope of practice of all EMS providers to administer vaccine, if so trained, I mean, that's suggesting that CMAC's already proving that that it's within the practice, and that it sounds like it's up to the region, like if they train their individuals. So I don't understand, like, I mean, that doesn't say anything about the governor's order or what have you. I mean, they say it's already within the scope of practice. So it sounds like that should be left up to the region to determine that, no?
Yeah, but I think, and I can verify it, but I think under the current programs that we're operating under, they can only do it if activated by an act of the commissioner. I can only do it at a vaccination pod, right? So those vaccine
Lou,
pods.
this is Nick.
Yeah.
Yeah, at the meeting, they voted this in, but as per an older executive order by the governor, it's only under public health facilities, not for EMS agencies. And I made that appeal to CMAC, and CMAC asked us to send a letter to have that changed. So as of now, my understanding is that we cannot, as an EMS agency, go forward with giving vaccinations in our agencies. They have to be through a public health facility. The other comment that I have is that it seemed to me, and that's the way I heard it several times, that giving the immunizations, swabbing people was part of the EMT's level of training or part of their curriculum. And I question that, and many people there said that it is, when I just don't know where that is. I don't know that we do any training in swabbing people, and it was suggested that it was easy enough to do, that we didn't have a problem with doing that. So I don't quite understand how we clarified that at CMAC.
Okay. So I would say that there's probably, I think that Doug brings up a very good point. By the way, Yoni, I do see your hand up. I will call on you in a second, but I do think that it sounds like we should consider starting to develop training and a process by which we can do this when and if it becomes available, without this real good clarification right now.
Accordingly, I'm sorry, Doug. Accordingly, they said that the Department of Health and Bureau of EMS does not have the authority to change that, nor does CMAC. It has to be done through an executive order by the governor.
Okay.
Is there a written language that the state has, or minutes or something that can be sent around? Because I think it sounds like there's a couple of different interpretations of what went down.
Yeah.
You want me to put up the CMAC?
I don't want to put up this report to REMAC. I'd like to get the minutes of the actual CMAC meeting and then send that out to our REMAC for review. So that, I think, is a better way, as opposed to trying to figure out what the interpretation of something is. Let's read it and then go off the original document.
Those minutes are not out yet, just so everyone knows.
Hey, Joe, I'm sorry. Joe, I just want to raise my hand when you get a chance. Say it.
Yeah, 1 second. I got Yoni and then you. So Yoni, go ahead.
Yeah, so to answer your, thank you for acknowledging me. To answer your question was, how does the members in the region feel about it? I think as a provider, I could say that I think they'd probably want to participate and help, as they, for the most part, feel like we live in the two worlds of public safety and public health. I think by doing it, it'll increase and expand access to vaccinations, whether to our own providers or maybe even to members of the public, and it'll allow them to kind of embrace that public health role. That's
great. Thank you. Glenn, and then Paul after Glenn.
Yeah, this is interesting because this stems back to 2009 during H1N1, where Governor Patterson had actually declared a state of emergency, and through the state commissioner of health, they were allowing EMTCCs and EMT paramedics to provide IN and IM vaccinations, and there are some stipulations. You had to be trained, so they have some just-in-time training. It had to be with a local or county health department pod, and then it expired after 30 days of when it was issued. So what they did at the state was actually go further this last time. They extended it to all EMS providers to be able to do intranasal and intramuscular vaccinations. So EMTs and CFRs as well. And also they extended the swabbing for testing purposes also to all levels of provider. We were trying to get something so that, not just, we can't specify to one thing, but if a COVID-19 vaccination came through, we wanted to see if we could extend that to an individual agency. And, you know, selfish reasons for us, we have 11,500 firefighters and close to 5,000 EMS providers and potentially family members. And if a vaccination were available, what we usually do is we use a temporary nursing agency. And in all honesty, nurses providing that service is really the best level. But we were told we're having a pod exercise coming up to give influenza vaccination at the end of the month. And already because of COVID in the other states, the temporary agency that provides nurses already advised us they have no nurses to provide to us. And so looking at that, we thought, wow, this is a small scale. If this were a huge issue, then we would want to try to extend. And so we really brought it up at the last CMAC meeting to see if we can extend that to local agencies under the medical director, the EMS medical director's direction, and, you know, training, all that to be in place. Again, only when there was a statewide emergency declared by the governor, and then corresponding to the health commissioner approving that as well. So it was extended in a different way, and Greenberg asked that, you know, I write a letter to CMAC to see about getting that, not just obviously during an emergency with the commissioner's approval, but now not just the local and county health department pods, but potentially within an agency. So I did send that letter up about 2 weeks ago, and I haven't gotten a response back yet.
Okay, thank you very much, Glenn. I think that's very helpful. I think that we, you know, I think maybe it's a good idea to kind of discuss this at protocol, start considering how we would implement this so that if and when it does come down, we're ready for it. So if, I know that Doug already has started working on this, and I thank him for that. Paul, Doug, 1 second. Paul had his hand up. I just want to go to him first, and then we'll go to
sorry.
You could let Doug talk. Let him finish the point. It's all right.
Thanks, Paul. Sorry about that. I didn't mean to be rude. Yes, so Yoni's he's working with me, and we'll have a draft of stuff for protocol to review. That was all.
Thank you. Paul, go ahead.
So I just wanted to speak in support of this idea, and I think it's more than just the medicine. I think it's really the scope of the EMS provider and the healthcare continuum. And we often, you know, lament what their roles are. And if we're kind of left standing at the train station on this one, I think we'll be putting a lot of good people in a lurch where there's job expansion and other capabilities for their training. And, you know, a paramedic is an all hands on deck kind of mobile provider. And when it comes to community paramedics and other types of integrated health, this is something where we have to push our people forward. They're the ones out there doing the blood and guts and the traumas and the grabs, but that's not a, you know, there are people who are going to continue in this career. We have to find these other roles for them because, you know, if you look at how COVID rolled out, churches were doing swabbing, minute clinics were doing swabbing, and other people, parts of the healthcare system were doing swabbing because we didn't have enough people to do it. And if there's an opportunity to push paramedics and EMTs into those roles, I think we owe it to them as their medical oversight. And I think we should support this 100%.
I agree. Thank you. Any other comments on the CMAC update? Like I said, I will get a copy of the actual minutes. We'll send that out to our region so that we can actually see what it really says. I don't want to misspeak or misinterpret something. So let's get the actual data from the state. Thank you, everybody. All right. Unfinished business. I don't have any that I can think of, but I do have a couple of pieces of new business.
I just got the REMSCO report. I don't know why I should be giving it or not, but Marie just sent it to me.
Would you like to? That would be helpful. Well, Bob's not on the call, and you're at REMSCO, so why don't you help us?
Okay, this is REMSCO, so I'll give you the report from REMSCO. The last time they met was on June 30th. We're going to meet again next week. The DOH, obviously, as everyone knows, extended a 1-year certification. Ambulance agencies are still trying to get their boundary maps all set. A bunch of them already submitted them. There was some issue with Bedford-Stuyvesant VAC saying that neither John Warwick or Shanda Robinson have anything to do with their agency, and they're not empowered to represent Bedford-Stuyvesant VAC. Co-sponsor renewals were renewed until September 30th, which is coming up any moment now. and there were multiple communications college-based courses requesting how they could possibly meet their requirements since the campuses are all closed. CUNY is probably going to stay closed for next spring as well, spring semester as well. So that's where that goes. I sit on Zoom all day long. It's ridiculous. There were recommended for reappointment at-large members were Vincent Barancos, Sean Graves, Jerry Grumbo, and Michael Stewart. Mitchell Powell, rather, I'm sorry. I don't know what I'm reading anymore. Members' terms are 4 years. Okay, the following were recommended for reappointment as organizational representatives from Greater New York: Samir McAchin, primary, and Allison Burke, alternate. There's a whole bunch of other things. I don't have to bore you with them. And I was blessed again with being reappointed as chair of REMSCO. Dr. Krupi is my first vice chair. Mitchell Powell is parliamentarian, and Martina Barcelona will be the secretary. That's a new appointment, and the officer's terms are for 2 years, ending June 30th, 2022. There were no applications for transfer of operating authority, no applications for determination of public need were received. I do want to tell you, in case you didn't know, that REMSCO's decision on Ezra Snushin was overturned by SEMSCO.
Any questions for you, Didya, on the REMSCO update? Okay, seeing none, let's move to new business. The bylaws committee met 3 times over the summer to put together a document that we all agree is fair and gives good representation to everyone. I'm going to share this on the screen. This will be the first reading or the first viewing of the bylaws. It needs 3 viewings in order to age and be voted on. So I'm going to put this up as the first version. Okay. So what you see here are the bylaws. Again, I'm going to focus specifically on the changes, but this documentation pretty much is the same. I will focus primarily, let's start with the membership. The membership was changed to include an additional physician, actually 2 additional physicians for the fire department, as well as breaking up the training and education physician into 2 what we call now paramedic program medical directors, and have a municipal as well as a non-municipal physician for that group. These physicians would sit on the training and education committee and would help participate in those meetings. We will be looking, again, this will be emailed out as well, but I have to put it up here so that you guys can see it for the first reading, so to speak, of these bylaws. The goal here is to have representation of all shareholders in our and all stakeholders in our region, and that was what we tried to accomplish. Again, most of this information is unchanged. I will send it out. We will send it out in a version where you can see the changes, so that you can view them. What I would like to say is that it's important to understand that members with more than 3 absences from regular meetings each REMAC year. This doesn't mean sequentially. This doesn't mean we have approximately 6 meetings a year. If you miss 3 of them, that will be considered voluntarily resigning your position. You'll be notified, and we will attempt to fill the position with people who are going to be at these meetings and be involved. It's important because there's a lot of people who have shown interest, and there are a limited number of seats. Alternatives can vote for their, a physician alternative can vote when their member is not present. The meeting times.
Not alternatives. It's alternates, not alternatives.
Alternates. I'm sorry. I apologize. It says alternates. I apologize for misreading.
Joe, who designates an alternate?
So positions have alternates designated on the membership list.
Okay.
designated by the assigning agency. So if you're in a position that is designated by an agency, you can have an alternative for those, an alternate, I'm sorry, for those positions.
Can someone say they're an alternate? Is there like an emergency alternate, or is it just whoever that person is?
They have to be listed on the membership as an alternate.
Thank you very much.
Okay, officers, there is a chair, a first vice chair, and a second vice chair, which shall be physicians, and they shall serve for a period of 2 years, and so on. This lists the officers, it lists the committees, and that there is a nominating committee for positions. Again, these will be mailed out so that everybody can see them, but this is the official first reading so that we can age these bylaws into our bylaws. Does anybody have any specific questions about the bylaws or about this document? I'm more than happy to entertain. I'm not going to read the document to you guys because you guys can read. And I'm more than happy to entertain any questions about what we did. I think that the group that was involved was very careful to make sure that it would be appropriate representation of all sectors or segments of our EMS system. Paul, I saw you put your hand up.
Great, thank you. Is an abstention still a no, or are we an abstention? Is that removing from the quorum?
So the quorum consists of the voting membership. You must have more than half of the voting membership. The membership that we will be having with all of our changes is a total of 31 members. So in order to meet a quorum, there needs to be 16 people present. All of those people have to vote in the affirmative for any action to be carried through. You need that majority of the quorum rather than the majority of the people sitting in the room at the time.
Understood. Can we remove the idea of an abstention?
No, you can't.
I still don't understand it.
So we have to leave abstention there, unfortunately, and an abstention is, for a better way of defining it, it is a no.
So an abstention is a term that comes from open meeting law. We have to leave it in place, but it is the equivalent of a negative vote.
All right, no worries, no.
If you look at
I'll abstain from pushing it further.
Okay, if you look at the last line of the thing, can you push down to the very bottom?
I will, I'm sorry.
Okay. If you move to the very bottom, which I can't see, okay, you will see that it says there that if any part of these bylaws in conflict with statute, the statute shall prevail, okay, and that is the issue, the open meeting law that we have no choice about. A previous governor put this thing through, one who was a very ethical governor, and you're stuck with it.
Okay. Any other questions about these bylaws?
Yeah, hi, it's Robert.
Yeah.
And I'm new, and I apologize for interrupting. I didn't see on this list an informatics physician. You all know that we're using Exchange ER, and I've looked at it quite deeply. I'm a member of NEMSIS, if you're familiar with the interoperable catalog that's used for promoting interoperability. But I don't see an informatician here, and I think that would be an interesting component for us to consider adding to our committee. Exchange ER is a hugely important element for us to extract data, as we saw in that excellent report on stroke. There are a number of items that we can pull, and many of us are using a common EHR platform. That platform today is not interoperable with our primary EMS EHR. I'm working with Stryker to create an interoperable crosswalk, but I'd like to, if the committee would so consider that we think about adding informatician to the group.
I think that's a very interesting point. I think that a lot of these physicians who operate in emergency departments, as well as emergency department administrators, are physicians who are well versed in informatics. I'm not sure that a specific, I don't know how you would define a specific informatician as you described. I don't know if that would be based on a certification or a.
I'm board certified in informatics, and I specialize in emergency medicine. I'm board certified in emergency medicine and informatics. And I look very closely at the Stryker EHR, because I've looked at many of them, and I belong to NEMSIS. If you're familiar with NEMSIS, NEMSIS is the catalog that we're all using to create that interoperable opportunity. And so when we talk about stroke, I was looking at the SLAM and wondering whether or not we have all of the items we need in the EHR to get accurate recording of the SLAMs as we need it. And we can go on. I don't want to take up everyone's time. It's just a thought.
I hear you. We did not think of an informatician specifically. I think a lot of these positions are physicians who are well versed in informatics as well. And that was the only. I don't think we even thought about it specifically. It's something that the bylaws committee can think about. I would ask other people on the call, if we do go and attempt to change this, we'd have to start the process of aging over again. So again, I do think it's important that having an understanding of informatics should be included. I do think that person could fit into some of these roles already, which I think would be beneficial anyways. I don't know if that makes sense.
Yeah, I'll take some time and write up some ideas for you to consider.
Great, thank
Marie,
you.
can you send Joseph email so I can reach out?
Sure. This will go out to if Marie is your contact person, if you'd like to send.
We go way back.
Perfect. That sounds great. Any other questions? Any other questions about the bylaws as they are put together? Okay, so I guess that information will come to the bylaws committee, and we will make a determination if we need to make a change or not. And if we do, the aging process will begin at the next meeting, I guess. Also under new business is, with coronavirus and the work that we've been doing on the bylaws, we have not we're at our 2-year point, and we have not had new nominations for officers. So I would open the floor as well as via email to anyone who is interested in participating as an officer of REMAC to submit their nominations to Marie, and then we can go ahead and move forward with that. And that's really all I have under new business. Does anybody have any questions about that? Comments, statements, anything? All right, I'm going to stop sharing this right now. Well, seeing none, I guess we can entertain a motion to adjourn.
Motion to adjourn.
All right. Thanks.
Good night, everyone. Stay safe.
Second.
Thank you, everyone.
Take care, everybody.
Thanks, everybody. Good meeting, Joe.
This meeting will be posted on our YouTube page. I'll send you the link.
Okey doke.